questions and answers at the end. You can ask a question by typing your question in the chat box at the right hand of your screen. Please close any other application or windows that you are not using to conserve bandwidth. And the webinar will be recorded and uploaded to our website within the next few days. And I'll pass it over to Dr. Patel to do introductions.
Thank you, Claire. Hello, everybody. My name is Premal Patel. I'm an associate professor in the Department of Medicine at the University of Texas Medical Branch, UTMB, in Galveston, Texas. I will be your facilitator for today's session. We're here to address a fundamental challenge in health education, and that is how to integrate social determinants of health education for trainees in a meaningful way. At UTMB, we've launched a groundbreaking initiative. It's called the Hospital to Home program in collaboration with a student-run free clinic, St. Vincent's Clinic. This program offers our medical students an invaluable experience by focusing on really understanding the social determinants of health in the context of patient care and with the ability to impact patient care. So today we're going to discuss the Hospital to Health program, its development, success within the hospital setting, what kind of experience it offers students, insights into the experiences and learning outcomes of the students that have participated, key lessons that have been learned, and a vision for the program's future. As the program is very collaborative, we have students, faculty, and an administrator here to share their experience with the Hospital to Home program. So now I'll let each person introduce themselves.
Sure, thank you, Dr. Patel, for that introduction. Hi, everybody. My name is Abhi Rao. I'm a fourth-year MD and PhD student and one of the facilitators and leaders of the Hospital to Home project. We are really excited to share the work that we've been doing this past year with you all today.
Hi, I'm Sarah Siddiqui, and I'm assistant professor here at UTMB, and I'm also the co-director for one of the courses in which Hospital to Home is offered in. It's called Health System Science and Community Service, and I'm really grateful for this opportunity and excited to be here today.
I'm Lori Looper. I'm the program manager for community engagement and education, and I also serve as a facilitator for the Hospital to Home program.
Hi, everyone. I'm Pam Embry. I'm also a fourth-year medical student at UTMB and one of the student facilitators for Hospital to Home.
Hi, everyone. My name is Diane. I'm a second-tier Master of Public Health student also at UTMB, and I also help with facilitating the Hospital to Home program. It's nice to have you all here, and we can't wait to start.
Great. Okay, so with that, let's dive in. I'll turn it over to Abhi.
Hi, everybody. So like Dr. Patel said, we are presenting a little bit about the Hospital to Home program, which is a value-added experience that we've designed for medical students to address social determinants of health at the bedside in the inpatient setting and facilitate that transition from the inpatient to the outpatient establishment at a medical home. So I wanted to first start a little bit by providing some context as to the communities that we serve here in Galveston County. So UTMB, this is Jenny Seeley Hospital, which is our only level 1 trauma center located in Galveston County. And it's actually located on the island. So as you can see down here, our county is separated from the mainland. It's about 45 minutes southeast of Houston. And we have an island and we have a mainland component that's connected only by a highway. And so we have significant transportation concerns that often serve as barriers for some of our patients. We have a mix of small towns and rural communities, as well as some larger cities that comprise the county. And importantly, we have about 15.7% of our population under the age of 65 that don't have health insurance. So these are folks who don't have access to Medicare and Medicaid for various reasons, including being undocumented and not having access to routine clinical care and other factors as well. So the Hospital Home program in general is kind of the brainchild of a larger movement to establish health system science as a third pillar of medical education. So I know I'm preaching to the choir here when we talk about the importance of health system science in designing effective medical education interventions for students. So as the COVID-19 pandemic especially taught us, social terms of health and conversations about health equity are so important early and frequent in medical education. So as you'll see, the Hospital to Home program is integrated curricularly across the MS1 and MS4 years. And it served as one of the main opportunities for both first years and fourth year medical students to engage with health system science. Most importantly, though, I think, is that this is a value-added experience for medical students. And not only are medical students kind of engaging with social terms of health education and understanding social barriers that might complicate the transition between the inpatient and outpatient settings, but they're also providing a service to patients and helping address some barriers that patients might be facing and overall smoothing that transition. So with that, I'll turn it over to Diane to give us a brief program overview of what happened in the SDOH visit.
Thank you, Abby. So we'll go over the program overview with the next slide. So basically what happens at hospital to home, we form teams of 2 students. Each team would have a first year and a fourth year medical student that and this experience will be integrated longitudinally into their curriculum. So it is part of the clinical skills course, which students take part in their first years, and then as well as the health system science course for the fourth year students. So patients that we identify for the hospital to home program are selected based on eligibility for community resources that we provide. Typically, we identify and target our interventions towards uninsured patients living in Galveston County or in Brazoria County. And the most common diagnoses that we address as part of the hospital to home program include congestive heart failure, diabetes, and hypertension. As we mentioned before, students will conduct social determinants of health focused interviews to identify unmet social needs as part of their experience. So we've collected normed screening questionnaires addressing barriers such as lack of transportation, food insecurity, financial instability, vision, or dental needs. And we use these answers to these questions to then connect the patients to community-based resources as well as provide medical equipment. So the resources would include St. Vincent's Clinic, which is our local free clinic on Galveston Island, which gets a lot of support from UTMB. So St. Vincent's hosts the care transition clinics, for example, which are kind of the point of entry of many patients that our students see in this program as they transition to be established at St. Vincent's Clinic. We also make connections to local charitable organizations, FQHCs, and food pantries, financial assistance programs. And finally, these are just like examples of equipment that we provide, like blood pressure cuffs, glucose monitors, log sheets, and digital scales. Moving on to the next slide, we are just detailing briefly what happens in hospital to home. So we usually start off with an introductory huddle where students will be assigned to the patients, and we do a brief Q&A. Then students perform the bedside consult. They do a brief chart review for the patient and then go into the room and conduct the interview to identify the unmet social needs. They come back downstairs after that to check out to student and staff facilitators who will guide the identification of resources in the community and then prepare and provide equipment and resource connections for the students to take back to the patients. Then students will be able to complete the progress note in the EPIC electronic medical records as a social documentation that will be visible to inpatient and outpatient care teams, and as well as provide important discharge information for the patient. And finally, students will be able to reflect and debrief on their experiences and just share what they've seen and what they've learned from the whole hospital to home session. Thank you. I'll hand it over to Pam for an example about a patient that we've seen.
Great, thank you, Diane. So I just want to present kind of an example patient so y'all can get a sense of the kind of history that we're taking and the kind of social documentation we can get out of the encounter. So let's take this patient, for example, KC. This is a 64-year-old woman with a past medical history of type 2 diabetes, hypertension, a history of transient ischemic attack, and chronic homelessness, who presented to the hospital with hyperglycemia and altered mental status. She has Medicaid pending, meaning she's currently uninsured, and her blood pressure on admission was 154/99. She does not have a regular relationship with a PCP and has not seen one for several months. And on admission, she was found to have a complicated E. coli UTI. Next slide, please. All right. So a comprehensive interview was performed focusing on the patient's social determinants of health and her unmet needs. And she was found to be at high risk for financial strain, housing instability, and food insecurity, although she did not have unmet transportation needs. At home, she did not have access to a blood pressure cuff or even a glucometer despite being prescribed insulin. And one of her high-cost medications included Lispro. So the depth of the interview really provided us with a lot of information that we were not able to find out just on our basic chart review, and this was not collected during her history and physical on admission to the hospital. So some of the resources we were able to connect her with were a Galveston County resource guide, which includes resources for shelters, transitional housing, rent and utility assistance, as well as the addresses and phone numbers for all of the food banks and food pantries in the area, support groups, and our local benefits office for assistance with Medicaid, SNAP, CHIP, etc. We also provided information about St. Vincent's Clinic, which, as Diane mentioned, is our local student-run free clinic, which provides not only medical care and medications, but also other services like counseling and financial literacy, as well as our own food pantry and transportation service. So we scheduled this patient for follow-up after discharge with St. Vincent's for continued management of her condition, as well as assistance with her medications. And we also helped her complete a St. Vincent's House food pantry application to address her food insecurity. On discharge, we provided her with a home blood pressure cuff, glucometer, glucose tablets, lancets, and test strips, as well as logs for her blood pressure and for glucose monitoring to bring to her post-discharge appointment. Finally, we provided her with coupons for prescription cost-saving programs and education on how to use these at her pharmacy. And now I'll hand it over to Dr. Siddiqui.
Thank you so much, Pamela. So now we're going to turn our attention to intended learning outcomes, what we're hoping for students to learn from this experience. As has already been described, so this is offered to 2 different courses. For our first-year medical students, it's through a clinical skills course called Practice of Medicine, or POM1. And then for our 4th years, it's through Health System Science and Community Service, or what's called HSS. So on our next slide, we'll be reviewing over the intended learning outcomes for our first years. So just to lay out some context for our first years, they're just starting off medical school. This is likely going to be one of their first kind of real world experiences where they're going to be doing an interview in a patient and doing the sort of experience with identifying unmet social needs for these patients. And so this is part of their clinical skills in terms of getting that one-on-one practice with person-centered medical interviewing. And then on top of that, they're also getting to take care of patients with diverse backgrounds, really getting to understand better their lived experiences in terms of the struggles that the patients may be having, either overall with their health or navigating the healthcare system. And so for those clinical skills, that's what we have listed here. In terms of communication, so the students are really getting the opportunity, along with communicating with patients, they're also communicating with their team members at a verbal aspect, but also in a written aspect. This might be the first time that they're getting early exposure to using electronic medical records, and then really getting the firsthand experience of kind of the impacts of social determinants of health in that patient care environment. And one thing that I forgot to mention, so these objectives that we have for our students, these are from the EPAs, the Entrustable Professional Activities. So this is the framework that we've used to identify the outcomes that were intended for our students. And then another important aspect to this on the next slide is the professional identity formation for our students. So really getting a sense, this is something that they're getting early on within the beginning of their medical school in terms of identifying how it's going to, what kind of physician are they going to be moving forward, and really having that opportunity to reflect upon after these encounters with patients in terms of what can they improve upon, and really getting that opportunity to do that and having that early on, and then being able to move forward throughout their clinical training with that in mind. So that's for our first years. And then as we move forward, so we have this opportunity as well for our fourth year medical students, and this is with the HSS course. And so what we have here is a summary of the course objectives that overlap with hospital to home. And as Abby had described, HSS is like the third pillar of medical education, and it really helps to contextualize how we're taking care of our patients. As we all know, we're in terms of caring for our patients, it's not within a vacuum, but rather there's so many different factors that are playing a role. And so this figure here, this is something that I'm going to be basically describing further along, but this is providing the different domains that make up HSS. So we have patient-centered care, high-value care, social determinants of health, and systems thinking. So as we go to the next slide, this sort of experience with hospital to home, it really allows students to adopt a systems thinking lens and really consider what's the big picture along with all of this. Like, what can we do to really ensure that our patients are having a smooth transitions of care? That along with the medical management, what other aspects are we needing to consider in terms of their unmet needs? And part of that that's really critical to this is that patient-centeredness. And so for our fourth years who have had this experience through their clinical rotations and clerkships, have already had a lot of practice in patient interviewing, but this sort of experience also builds on really doing more advanced interviewing with extended social history. And they end up becoming an example for their MS1s as well, in terms of how to go about with doing this sort of interviewing, where you're really learning more of the lived experience for our patients, and then taking that and synthesizing it with their clinical presentation with the hospital course, and how to individualize a plan that's going to be more intentional and allow for a more safe discharge for patients. So if we continue to the next slide, we're building on this framework of HSS, where we've got systems thinking and patient-centeredness. And now when we have these other aspects also tying into it, social determinants of health, high-value care, and health care economics. And one of the examples that really helps to tie this all together is when we have patients with insulin-dependent diabetes who are uninsured, and oftentimes they're coping with food insecurity. So what our students are really getting the opportunity to see is, how do we apply high-value prescribing? So along with having that knowledge of the different types of insulins that are there in order to manage diabetes, understanding also the cost barriers and affordability is really important. And then along with that, those patients who are identified with food insecurity, what are the pathways to link them for the community resources in terms of referrals to food pantry, or referring them to a medical home? What's the approach in terms of those linkages? So once again, we see those intersections with these different concepts. And as we move forward to the next slide, we tie in additional domains, for example, healthcare process and team-based care and leadership. So, with this hospital to home experience, students are really recognizing we have to collaborate with a whole team, that it's engaging care management, social work, nursing, allied health, pharmacy, and so forth, to really come together for this discharge planning for our patients. And really this is key for our students to learn, especially for our fourth years who are soon going to be residents and be our future physicians, to really see they're going to be leading the teams to help with really synthesizing and coming together with this sort of discharge plan. And so with that, we do have one other additional example, but I'm going to move forward because I want to make sure we have enough time. And I do want to say at this point, in terms of with this examples that we're giving, how for this hospital to home experience, it really helps for our students to really get a grasp on how important it is to take that systems thinking approach. So I'm going to hand it off to Abby now for the implementational considerations.
Discussion, Dr. Siddiqui. I think there's a lot of really rich educational opportunities for students as part of this experience. I wanted to quickly go over some of the implementational considerations that we had to keep in mind in the early days of the hospital to home program. Hopefully this will serve as a guide and offer some pearls for those who might be interested in implementing similar approaches at their institutions. So if we move to the next slide here, one of the key realizations that we had in developing the hospital to home experience was that there is a great diversity of stakeholders that have a part to play in determining how successful this program would be. At the top, we have health system leadership, who typically is focused on 30-day readmissions rates and reimbursements from CMS, and focus on identifying patients who are at high risk for readmission. And many times we get referrals for hospital to home patients from our health system leaders who identify these patients at high risk for hospitalization and who would love some support in making sure that we bring down those readmission rates and help manage some of these chronic conditions that our patients might experience. We also have, on the left-hand side, we have educational leadership and learners who are focused on providing a good experience and a great opportunity to engage with social terms of health. And so one of our key conversations in the beginning was sitting down with educational leadership and explaining to them what we intended for students to receive from this experience. One of the unique aspects of this experience is that not only is it kind of a hands-on approach and understanding social terms of health with real life examples, but it's also an opportunity for students to see themselves as agents of change early in their medical careers. And I think that has a lot to say about their efficacy as providers moving forward in the future. On the bottom, we have care management and inpatient medical teams who are focused on making sure that our patients that are seen through the hospital to home program have a safe place to be discharged. And so oftentimes we will have ongoing conversations with the care management and medical teams to ensure that we are able to make that transition from the inpatient, the outpatient setting as successful as possible. And of course, at the center of this whole experience is patients, families, and communities. And so we want to make sure that the hospital to home experience is serving our patients very, very well and making sure that our patients are able to take advantage of some of the resources that we are providing. And so that is a big area of growth as we move forward and continuing to evaluate our impact, is to understand how patients are utilizing some of these resources as part of hospital to home. And then finally, and most importantly, is our community partners as well. Many of our referrals in the hospital to home setting are to our community partners who assist with things like food insecurity, with housing instability. And so we want to make sure that these referrals are both intelligent in the sense that they are able to directly address the needs of our patients, but also working with our community partners to ensure that we don't overwhelm systems that already exist, and figuring out how best we can integrate this experience into the community framework as a whole. And so a lot of these conversations have been happening in parallel over the past couple of years, and that has really allowed us to understand what the role of hospital to home is within the larger UTMB and larger Galveston County community. I wanted to go over really quickly a couple of implementation considerations and some challenges that we had faced very early on in developing the hospital to home program. I think one of the first glaringly obvious challenges that we encountered was that first-year students who would often engage with hospital to home for the first time in the fall semester, very shortly after they've taken their anatomy course, they understandably have little exposure to inpatient medicine. And so this is one of the reasons we leaned on the fourth years who are also participating in this experience as part of their health system science course. We leaned on them as mentors who kind of provide structured feedback and guidance to support this clinical encounter. And so over the past couple of months, we've been really working hard to ensure that MS4s, that fourth year medical students, have the opportunity to provide some structured feedback on basic patient interviewing skills, basic conversation techniques and motivational interviewing techniques. And that's been something that we found to be really, really successful. And then on our end, in terms of facilitating some of these conversations, we put in a lot of effort to create interview scripts with simple questions that are nationally normed to address relevant social terms of health. So on the next slide here, I have an example of some of the direct questions that we encourage our students to ask. So as you can see here on the left-hand side under housing needs, we ask students to ask these questions, which are based off of the Health Leads nationally normed kind of questionnaire. And based on these responses, we identify resources that might benefit our patient. But we also encourage students to ask further questions to really understand the context and the social context and the social determinants that might be interacting in this patient's experience. And so with that information, we encourage students to think about how sometimes there might be complexity in these social situations, and how can we ensure that the resources that we are providing are not just checking a box, but rather able to address some of these complex needs. And so we do have this interview guide, and we've noticed that it makes first-year students very comfortable with figuring out what to say during the interview. But we also encourage some level of flexibility and some level of adaptability that are both our MS4 students support, but also we encourage that in our MS1 students as well. Another one of our implementational considerations is that in general, our medical students are not aware of community resources that are available. And so we have an amazing social worker at St. Vincent's, Shelley Wolf, who spends a lot of time designing these resources and ensuring that these are viable options for our patients. But we also have trained student facilitators and staff facilitators like myself, Lori, Pamela, and Diane, who are undergo training to be aware of these resources. And on top of that, we create some streamlined protocols to connect patients to resources so that the burden of identifying what resources might be most helpful for this patient don't fall on the students, but rather fall on protocols that we've designed far in advance. So to provide a quick example of this, this is a flowchart we created to look at how we can establish patients in the outpatient setting if they do not have an established PCP. So as Diane mentioned earlier, CTC clinic is typically our point of entry for patients who are entering St. Vincent. So any patient who is being seen by St. Vincent's for the first time after their hospitalization is seen at the care transition clinic. And we have this decision algorithm to allow students to kind of feel comfortable in deciding where to send referrals for our patients. And so based on, I won't go into details here, but based on where the patient lives, the patient's insurance status, we are able to make some decisions as to where the best place would be for them to establish a medical home. And these blue boxes here, kind of in the corners, provide some very clear instructions for the students to facilitate these referrals and make sure that we are able to close that loop additionally. And then as we move forward, facilitators also play a role in ensuring that these follow-ups are scheduled and ensuring that patients are able to make their appointments. And that's actually an area of analysis, is how successful that these interventions are in terms of establishing patients. I wanted to really quickly go a little bit over some of our initial measures. So we are really excited to share that we have begun the process of understanding our impact on the health system as a whole. And as you all are probably acutely aware, it is a very complicated thing to understand how social determinants of health interventions could impact complex medical situations in multiple healthcare systems. And so our impact so far this year, over the course of this academic year, we have seen over 236 patients as part of this program. And students have been able to provide 92% of patients with the resources to address social determinants, whether that is referrals to food pantries or whether that is medication assistance programs or referrals to our clinic. We are starting the initial process of analysis to figure out exactly what the impact on the health system is. And so using some of our EMR data, we are looking at whether the hospital to home program, or at least the initial hospital to home visit, is having an impact on ED, emergency department admissions in the UTMB system. And so one of our analysis shows that in high utilizers of emergency departments, we define that as greater than the 90th percentile of average number of ED visits. The hospital to home program seems to be having a little bit of an impact on the number of visits that they have before and after the intervention. And so we ran a pretty simple paired t-test before versus after the hospital to home visit. And we found that this data is actually approaching significance, which is really, really exciting. Of course, this is still preliminary data, and still there are a lot of other factors that we need to look at that might be confounding this relationship a little bit. This is still an encouraging first step. On the student side, we are also looking at how well our program is addressing some of these educational outcomes that Dr. Siddiqui has carefully outlined earlier. So as part of their exit paperwork, the students actually perform a reflection, and they do an online reflection where they actually reflect on how the experience allowed them to accomplish certain entrustable professional activities that Dr. Siddiqui mentioned earlier. We found overwhelmingly that students largely agree and strongly agree that this experience provides them with opportunities to apply patient-centered interviewing skills, to understand how social terms of health affect all sorts of health risks and outcomes, practice some of their documentation skills, utilize community resources to provide comprehensive care, and understand that health is this multidimensional state of physical, mental, and social well-being as defined by the World Health Organization. And so the N here is 548. So that means that every student who has participated after every session actually concludes this reflection. And with that, I'll go ahead and turn it over to Lori Looper, who will tell us a little bit about student feedback specifically.
Thanks, Abby. So I wanted to provide a little context on the student feedback. At the end of each hospital to home session, as was mentioned earlier, we engage in a few different activities to help students reflect and consolidate their learning. First, we ask them as they're returning from providing those resources to patients to sit down and do a 1-minute write about what they want to take away from the experience, what they felt was meaningful to them. We also then ask them to complete that feedback form, which contains both quantitative questions, which Abby addressed in that last slide, but also some qualitative questions. And we use that information from that form to make informed decisions about improvements to the program, as well as to gather the student perspective on what's meaningful to them from the experience. And then lastly, we wrap up with a verbal discussion. So if you want to go to the next slide, we can talk about some of those qualitative questions in that form. So the first open-ended question we ask is, what went well today? And we see from some of these exemplars that students frequently mention the gratification that they derive from spending time with patients, getting to really know what their situation is outside of their medical conditions. And then they typically very much enjoy providing resources to those patients, helping to ensure that they have a better outcome, and learning about the resources so that they can be more effective with other patients as well. And I think, students also frequently report kind of seeing themselves as those agents of change, being able to make a difference in the life of a patient. Next slide, please. We also ask what didn't go as well as you would have liked. And so this is very helpful to us to find some areas that we can improve procedurally, such as patient selection. But it also, I think, is very indicative of some of those areas of productive struggle for the students. And, sometimes it's where we are struggling to accomplish something that we experience the most growth. And so you can see that some of the students talked about, just wanting to work on their interview skills, wanting to work on their understanding of the electronic medical record, and so forth. Next slide. The next question really addresses that professional identity development that we were talking about earlier. So what are some personal goals for improvement based on their experience? And these tend to be very wide-ranging, everything from, I want to learn to speak Spanish to, being more well-versed with the resources for patients, asking more questions about those social determinants of health with their patients. And I really liked the response, no assumption about patients. One of the questions that I like to ask in that verbal discussion at the end is, would you have known that that patient was experiencing those difficulties had you not conducted the interview? And I think it's very telling for them to realize that the patient chart is not necessarily going to have all the information they need to help a patient be successful. Next slide. The other feedback that we've got is that both MS1 and MS4 students have expressed a lot of satisfaction with that mentor-mentee relationship in the paired teams, especially early in first year. That seems to be very valuable to the first year students, but I think the fourth year students also have some pride in seeing that they have developed as they have gone through their training, and derive some satisfaction from feeling that they have something to offer to those MS1s. And now I think I will pass it to Pam to talk about our next steps.
Great. So, like Lori mentioned, I'm just going to talk about some next steps for the program. So one of the things that we've done, as you've seen, is implement these surveys to the students who've completed the program. And we really do use the responses from those surveys to improve the process. Most of actually all of our fourth years who have done the program did not have this opportunity as first years. And so a lot of the feedback we get is about things that they wish they had known going through clinical rotations, which is really helpful for us to figure out how to educate the students about the resources that we have, and how to find those resources that are available to them, not just in Galveston County, but in general, so they can use those lessons next on in residency. Could I get the next slide, please? Thank you. So another thing, which I think may have been alluded to in the chat, is that we also would like to get more students involved from other schools at our institution. This truly can and should be an interprofessional experience, because it should not just be on the medical students to be implementing these changes in an attempt to improve patient outcomes. So we're also working on including students from the School of Allied Health Professions, as well as students from the School of Public and Population Health. Next, we would like to improve our measurement of health outcomes and risk reduction. One of the difficulties that we've had in the H2H interactions is in measuring how many of the resources are actually utilized by our patients. So we're in the process of implementing surveys to patients at our care transition clinic for their post-discharge appointment to see how many resources they're actually able to use, which might have been too challenging, and which they did not use at all, as a way to kind of guide us to see which resources are most useful for our patients, and also how we can improve our patient education about the resources available. And finally, we would also like to expand this program to include the emergency department, not just the inpatient floors. As we've mentioned previously, there are some patients who end up being high utilizers of the emergency department, either because they don't have a primary care provider or don't have access to medications outside of the hospital, but these patients may not necessarily be sick enough to be admitted. So it could really greatly benefit them for us to be able to see them in the emergency department. We just may have a little bit of a trickier time targeting them because the encounters are so much shorter. But we definitely could get them plugged in with our St. Vincent's House and establish a medical home for them. So all in all, this program, I think, has been really successful in getting students involved and educated on social determinants of health, as well as empowering them to seek out further opportunities in the future. Our feedback has overall been extremely positive, and we hope to continue growing and improving this program.
Thank you so much. I really appreciate all of the amazing work that you all have done and highlighted here today. At this point, I'll ask for any questions from the attendees, if you can write it in the chat. And I guess I'll go first. So I was curious to hear about the origins of hospital to home. What do you feel were some of the key motivations in its development? Was it a need for patient care and navigation of community resources? Was it more anything that was particularly lacking in the medical school curricula? Just, how did this organically develop?
Sure, I can take this one. So, and feel free to jump in, other panelists, if you have anything to add. But I think one of the primary motivations for beginning the hospital to home program, I think, came from both the St. Vincent's Clinic and from health system leadership. And so in early conversations, we actually saw that there was a population of high utilizers of inpatient and emergency department care, many of whom we realized could benefit from referrals to St. Vincent's. And so one of the initial conversations we had was, how can we ensure that some of these high utilizers of care, how can we ensure that we are able to reduce their readmission rates into the hospital and give them some of the social resources that could help them in navigating that transition. And we found that St. Vincent's, the clinic especially, has been a key player in ensuring that some of these patients receive follow-up outpatient care and are effectively connected to community partnerships and community resources that are available. The educational side of things, I think, came a little bit later, but I think it is a very, very valuable piece in ensuring that students kind of have this opportunity to engage with social determinants of health. In our early days, we had a lot of, while we were kind of piloting this experience, we had a lot of opportunities to engage with social determinants of health. And me personally, I gained a lot from engaging with these patients and understanding how unique social barriers might impact their journeys. And so I think that was all the more reason to kind of advocate for this to be a longitudinal experience for medical students across the years of medical school.
Great. I see in the chat that there are others that have somewhat similar programs as well. So this is definitely in keeping in line with what I think many academic institutions and health systems are moving towards. You all mentioned plans to expand hospital to home, maybe in the emergency room, and perhaps even incorporating interprofessional teams. I'm curious what steps have been taken to ensure sustainability and scalability. What are your thoughts on that?
I can address the sustainability issue. So as you can see, we have a lot of student workers who are facilitators for the hospital to home program. And much to my dismay, they leave every year. But that's okay. They're going on to carry on good work elsewhere. So we have in place some training materials that we have developed in regard to hospital to home to continue to, develop skilled facilitators to take on for the next year.
Fantastic. And one of my last questions is, the hospital to health home program seems to be really integrated into the medical school curricula. Do you think that there are future possibilities for further integration? And what do you think would be those steps?
Oh, you can go ahead and take. I think Lori, you unmuted. You're more than welcome to.
No, that's fine. Go ahead, Dr. Siddiqui.
I do think there are opportunities. I think one of the things we've already discussed about is how we'd like to have a more like interprofessional component to it. So I think that would be a way for integration across schools. And then in terms of future aspects of it, I think some of the things for us to consider also is for our fourth years, they're describing how, we wish we would have had these experiences before. Now that it is for first years as well, we have that component, but how do we go about, I guess we have to develop a way of integrating this during second and third year as well. And I know we're going through some curricular changes with our medical school. And so this might be one of the things that we need to discuss further about is how do we make it cohesive or threading it through all 4 years.
Great, thank you. For those that are thinking of doing something similar and having a similar program, what is kind of the one piece of advice that you all would give them?
I think really quickly, I think one of the hardest things about the initial stage of this program was logistically making everything happen. So as I'm sure everyone in the medical school curriculum development world knows, the fourth years are often all over the place with interviews and with residency related things, and first years are often spending a lot of time in the labs and developing their clinical skills elsewhere. And so one of the things that I think was really success that allowed our program to be as successful as it was creating flexible opportunities for students. And so actually we have the staffing to run hospital to home 4 days a week, essentially 6 months, 6 to 8 months out of the year. And so we just kind of wrapped up recently for Christmas. In fact, we have another session today for hospital to home. I think one of the I think that's been really helpful, and we give fourth years that flexibility to be able to kind of use this experience in between some of their other clinical rotations. And first years are scheduled to participate in this experience as part of one of their introduction to doctorate courses. And so they actually are scheduled to attend these events once every month or once every couple months or so, depending on the availability and things like that. So that's one of the things I think that was central to the success of this program. And one of the things that in a medical school that has over 250 students per class has been definitely a big challenge.
I would also say that one of the critical keys, I think, for the successful development of the program was to have a pipeline for getting that feedback from students and acting on it. So we do meet every 2 weeks and discuss what the feedback has been since our last meeting. Is there anything that's popping up that maybe we need to address? And we discuss that as a group and, try to determine, is this a one-off situation or is this something that's, programmatic that needs to be addressed?
And then one other thing to add to this also is, I think Abby had mentioned about how we had the buy-in from leadership, which was a critical component. The other thing is the fact that this is like a co-creation with students and faculty and administration. So it's all coming in together. And I think that was another thing, how we were organically able to bring it all together with this collaboration for the success of this program.
All right. So I don't see any questions in the chat. I want to thank you all for being here today. And to those attendees, thank you also for attending. I think today's discussion has really highlighted that programs like this can really be transformative, not only for learners, but also for patients, and that there are remarkable synergies among academic institutions, health systems, community partners for being able to move the needle on social determinants of health. So as we conclude, I hope that we carry forward some of these lessons learned and the vision that was articulated today. And continue to prioritize kind of understanding and addressing social determinants of health in patient care. I'll turn it over to Claire now.
Awesome. Thank you so much for presenting. I dropped the evaluation link in the chat box if you can take time to fill that out. And I also want to share that our conference is coming up at the end of February. I put the link for the website in the chat box as well. We hope everyone will join, and thank you everyone for coming today and presenting.
Thank you.
Thank you so much.
Thank you all.
Thank you for having us.
All right, happy holidays.